you. Hello and good evening. I'm not all that au fait with this technology, but I'm going to go with it. Um, breast symptoms are really a very common presentation, I think, in general practice. And fortunately, most of these are benign, and apart from reassurance and some minor intervention, require no more treatment. 1 in 8 women in this country do develop breast cancer, and obviously that creates a lot of anxiety in the population. But fortunately, mostly we're able to reassure our patients. And I'm going to try and cover most of the areas that I see referred to me in my practice. And hopefully this will give you some clearer understanding and tools that you'll be able to use in assessing and managing them. The problems that I see referred mainly are breast pain, breast lumps, fibrocystic disease, which is really just a variation on the breast pain and breast lump symptomatology, nipple issues such as discharge and other abnormalities because of the fear of Paget's disease mainly, I think, a number of inflammatory breast conditions, Gynecomastia, and also some imaging issues that are referred along because of not complete clarity in regard to the reporting, and in the main, that is associated with calcification and possibly risk assessment, because I've sent quite a lot of ladies who are concerned about their families and their risk and how to best manage their monitoring and their follow-up. If there are other issues towards the end that I don't cover in this, by all means, just let me know and I'll try and get on to that. Now, when it comes to assessing breast pathology or breast symptoms, I think we should really go back to the beginning and remind ourselves about triple assessment or triple testing. And that means, firstly, a comprehensive clinical examination. Secondly, imaging, which is usually ultrasound with mammography, although today you are all aware that there are new technologies available such as MRI and contrast mammography, and I'm going to just touch on these very briefly to tell you where I believe their place lies, because I think there's quite a lot of confusion relating to when to use an MRI, when not to use it, contrast mammography, and so forth, and a non-surgical biopsy. And in non-surgical biopsies, we mean either a fine needle aspiration, a core biopsy, or some sort of vacuum-assisted biopsy. Our preference always is to go for a core rather than a fine needle aspiration, although sometimes an FNA is a valid test to perform. Now, all of these in triple assessment need to be benign and concordant for you to be able to call a finding benign. If any of them are not, or they're vague, or they're unclear, then that doesn't pass the triple assessment test. And then you need to consider whether or not you want to refer this on for further assessment. So this really forms the basis of all of our assessments of breast pathology. Now, I'm just going to briefly touch on MRI. It's a very sensitive tool, but the problem with it is it's not particularly specific. And so it can actually raise a lot of issues that can be quite difficult afterwards to sort out. It's also expensive if it doesn't fall into the rebatable group. And they're the people with BRCA genes, with strong family histories, with inconsistent findings clinically and on imaging. So our tendency is to use it selectively. And that's mainly for people who've got very dense breasts, such as young women with difficult clinical situations, families where there are genetic abnormalities or appear to be genetic abnormalities, where we see disparity between the clinical findings and the imaging report. For instance, if a patient is referred with a 2-centimeter carcinoma of the breast and they're examined and it feels like a 5-centimeter carcinoma, people with implants, because it helps to separate issues related to the implant from other breast pathologies, and particularly with lobular cancers and multifocal disease, to try and sort out if the multifocal issues are cancerous and if there is lobular cancer, which is notoriously difficult sometimes to diagnose on conventional imaging. The other more recent test that you may have seen around is contrast enhanced mammography. And that's the use of an intravenous contrast with a mammogram. It really is just a software thing that needs to be added onto the mammography technology. And it relies on the fact that as a tumor grows or a carcinoma grows, it develops a neocirculation, and you have leakage in these vessels, which then can be picked up on the mammogram in those masses where it's occurring. It is cheaper, and in some ways it's rebatable. It only requires a regular mammogram machine. And we use this with multiple complex masses, which are seen on ultrasound, or even patients who would like to do an MRI or have an MRI performed and can't for various reasons. Now, I think if we start with breast pain, which is really a very common presenting symptom, both I'm sure in your practices and what I see, or mastalgia, the first thing to keep in mind is that it's a very uncommon symptom of breast cancer. It's usually associated with the underlying pathologies that you can see there: hormonal mastopathy, fibrocystic disease, and really the complications of fibrocystic disease, such as cysts which become inflamed and tender, or ductectasia, pubertal changes, pregnancy. In menopause, it's quite common, particularly in the premenopausal or perimenopausal stage, and then tends to settle. And sometimes drugs are associated with mastalgia, such as antidepressants, hormone replacement therapy, which is not an infrequent cause, spironolactone, and digoxin. Now, what do we do with people with breast pain? How do we assess them? Well, I think initially and mostly you can work out most things from the history. So we need a menstrual history. Are they premenopausal, perimenopausal, or postmenopausal? And if they're postmenopausal, you need to know if they're on HRT in the main. The next thing we need is to know is whether or not it's cyclical or non-cyclical. And we tend to separate breast pain into these groups. Cyclical is the most common form of mastalgia that we see, and it really is associated with the menstrual cycle. It sort of develops a few days before the cycle, then settles, then recurs. Non-cyclical breast pain is more likely to be associated with local pathology. We also ask if it's unilateral and bilateral, because bilateral is the most common, and once again that goes with the menstrual cycle and is cyclical. The clinical examination in these people is very varied. Often it's very normal, but at other times there can be fullness and lumpiness. And once again, this is more common in this cyclical type of mastalgia, and most commonly felt in the upper outer quadrant. Imaging is performed. I think you need to image most cases. I think that if you've got young patients who've got a very typical history of cyclical mastopathy without much in the way of clinical findings, it's perfectly reasonable to reassess them after their menstrual cycle or over a few months, and then decide whether you want to image. But all other people do need imaging, whether it's cyclical or non-cyclical, and particularly in the non-cyclical group, because that's where you may find more in the way of pathology. What is the treatment? Well, if you do find an underlying cause, such as a cyst, which is causing pain, or some form of infective process, such as with ductectasia, then you manage this. You may drain a cyst. There's an infective process. You might prescribe antibiotics. The other most important thing you can do for a patient is that if all of the investigations appear to be benign, and you're fairly convinced that this is a benign cyclical mastalgia, then reassurance. And there have been a lot of studies which have shown this is probably the most important thing you can do for the patient. And I must say that when I see patients with breast pain or mastalgia, and I reassure them that this is just a benign physiological event, which is quite normal in by far the majority of women, they become relaxed and they tend to forget about the problem. Now, if there is an issue and it's uncertain whether it's cyclical or what's going on, you can ask the patient to have a pain chart and to log where their pain is, and that way you can review them a bit later and see if there's any pattern to this. Well-fitting bras have been shown to be useful, and certainly underwire bras can dig in and cause mainly inframammary discomfort medially and laterally. Of the other medications and treatments that we've got, evening primrose oil, which is really based on a thought to be deficiency of essential fatty acids, has been shown in a number of studies to have some benefit. Vitamin B1 and B6 and dietary measures, such as reducing the caffeine in their diet and the salt in the diet, haven't got a lot of support from studies, but they seem to work, and I certainly use all of these, and I find that a not insignificant proportion of women with vitamin B complex and dietary measures alone seem to settle down, and that may be associated with the fact that they've been reassured as well. If you have a patient who's got short-lived episodes of cyclical discomfort associated with the periods lasting a couple of days, then analgesics and even non-steroidal anti-inflammatories can be useful over a short period. The pill has been put up sometimes as useful in the management of mastalgia. If you look at the studies, it's very variable. People have compared various types of pills, various dosages of pills. I don't use it, and I'm not sure of its value. Other medications which very rarely are used by us because of the issue associated with their side effects are danazole and bromocriptine. Danazole's effect is really on the ovarian pituitary axis, and it does give some benefit in studies. Its dosage is very varied, and if you give higher dosages, you do get the side effects, which really are amenorrhea. Bromocriptine is based on the fact that there are some studies which suggest that prolactin is a problem in mastalgia in some patients, and as this reduces the prolactin levels, it was used in the management of mastalgia. The trouble with bromocriptine is that it's got about a 20% side effect profile, and this is dizziness, nausea, and vomiting. So we don't frequently use this. Sometimes and rarely with really refractory pain, we might use danazole, and I suggest that you start with a lower dosage, and it can go right down to 25 milligrams. And tamoxifen I never use for breast pain, but it has been listed as one of the treatments. So what do you do with people with breast pain? I think you're all well versed on how to manage this, and mostly they can be managed in general practice. When do you need to do something more about it? Well, I think firstly, if we look at the bottom line, if they're not settling and it's debilitating, sometimes you just have to get them looked at by somebody else to be able to reassure them, and that often will do the trick. Or if not, then we may have to move onto more complicated things like the danazole or bromocriptine. The other group, I think, if you've got any doubt regarding a triple assessment, if it's been performed, and particularly if the patient's complaining of very focal unilateral symptoms by any sort of asymmetric breast examination, you need to get that looked at. I did mention before that breast pain is very rarely associated with breast cancer, but On occasions, it can be, and you sometimes will see a patient who says, I've got pain, and then on further investigation, they do have an underlying neoplasm. And so people with focal signs, rather than the bilateral cyclical type of pain, may need referral for further assessment. If we now look at breast lumps, which is probably the second most common thing we see, firstly, there are the patients that are referred with nodularity or thickening in the breasts. Now, this is often a very difficult clinical situation to sort out. It's common, particularly in young women. It's most commonly a normal physiological event, which is benign and cyclical. And if you have a patient like that who comes complaining of nodular or thickened breasts, and they fall into this group of young women, which is it's cyclical and they're young and there are no other specific features. I think, as I said before, it's much the same as the pain. It's reasonable to watch them for a little while to see if this is cyclical and disappears after the menstrual cycle, and then maybe no further investigation or treatment is required. This isn't always the case with nodularity and thickening. And the group that you've really got to watch out for is if it's asymmetric and discrete and persists after short period of observation, then even if you've had mammography and ultrasound and this is normal, they do need a biopsy into that area. And the reason is that lobular carcinoma and DCIS may be very, very subtle, not seen on imaging, but only clinically palpable as some thickening. So if you do have people with focal asymmetric signs, sure, you can watch them for a short while, but if it persists, even with negative imaging, I suggest you go to a biopsy. Now, you might want to go to things like MRIs, and you may want to go also, particularly if they've got very dense breasts and the mammography is not that useful, you may use an MRI or contrast mammography, but eventually you will still end up biopsying these people. Fibrocystic disease is really a term which some people don't even like to use anymore. It's really a range of benign findings that we find in patients. It's often cyclical and it's normal physiological changes, and it presents with lumpiness, discomfort, pain, often thickening with benign imaging findings such as cysts, dilated ducts, and densities. But if you've got any doubt, even though a diagnosis once again has been placed on a patient of fibrocystic disease, still consider biopsying, particularly if there's anything atypical or it's unilateral or asymmetrical. There's no harm in getting a biopsy and being able to reassure a patient rather than missing significant underlying pathology. Now, the most common benign lump, I guess, that we see is a fibroadenoma. And that makes up about 12% of the lumps in the breast. And it peaks in the early or mid-20s. And very often they're multiple. On imaging, as you can see here, and I'm sorry, I don't have a pointer. I've got no idea how to use one here. They're well defined. They've got this soft globulation on imaging. They're hypoechoic, which means they're less dense than the surrounding fat and breast tissue. And you will have a significant proportion of fibroadenomas reported on as having calcification, which is quite coarse. That doesn't mean anything's going on there. It's a degenerative finding that we see in fibroadenomas. These people need triple assessment. They need a biopsy. And once you've got a diagnosis of a fibroadenoma, then usually simple observation is fine. And if you want to know how often to follow these people up, I think if you've got a very definite diagnosis of fibroadenoma, I'll often see them after about 6 months with a follow-up ultrasound just to be sure that it's stable and not enlarging. And after that, just back to their normal routine reviews that they've had. They don't need lifelong 6-monthly reviews. Fibroadenomas are not precancerous. What are the pitfalls with fibroadenoma and how do we avoid them? Well, the pitfalls are really phyllodes tumors and cellular cancers, which can look exactly like fibroadenomas on imaging. Well-defined, quite lobular, and don't look in any way different. Now, the way we try and avoid things, obviously, is to do the triple assessment and to have a core biopsy performed. And any suspected fibroadenoma, but with atypical features on any of the triple testing, does need excision. So if you think it looks like a fibroadenoma and it feels like a fibroadenoma, but the core biopsy says that it's a cellular lesion but doesn't mention malignancy, that probably still needs to come out. And on occasions, the core biopsy and the differentiation between phyllodes and fibroadenomas can be quite difficult, and that's why I tend to follow them up after 6 months. The other group that need to come out are those that are over 3 centimeters, and some people will draw the line at 4, and you'll always find varying opinions. Or those that are significantly enlarging. They need to come out because they can achieve very large sizes, 9 centimeters, 10 centimeters. The other group that we take them out for is when a patient requests excision despite a very thorough explanation of the condition and the findings and the results you've got. Because there are some patients who just won't tolerate, at least for the first time that it happens, a lump in their breast, and you need to take it out. And then there's the question of what happens over the age of 40, because fibroadenomas rarely occur over the age of 50 de novo, and there are people who will suggest that if a fibroadenoma is new, despite negative investigations, over 40, then it may deserve excision. I sort of assess the patient on its merits and make a decision after I've seen them. But this group probably needs to be looked at as well and could be considered for excision. And even large, I'm sorry, it's a bit messy, this slide, but even large fibroadenomas, and this is from the periphery of the breast, that I've managed to remove through a periareolar incision, can be removed with very good cosmetic results. So this patient has had a large tumor from the lateral part of the breast excised, and there will be really very little in the way of post-operative scarring. Now, other less common benign findings apart from fibroadenomas, hamartomas, which you will see in reports occasionally, lipomas, neurofibromas, and a condition which you may have seen mentioned, pseudoangiomatous hyperplasia or PASH. Now, all of these are benign, and unless they're enlarging or look in any way suspicious on triple testing, don't need any further intervention and can be left alone. What about breast cysts, which is the other large group of breast lumps that we see, apart from the solid ones? Once again, you need to reassure the patient it's very uncommon for a cyst to be cancerous or precancerous. They usually peak in incidence in the 30s up to the 50s and around the menopause. And usually, if you've got a patient who's got problematic cysts, you find that following the menopause, they will just sort of dissipate and no longer be a problem, unless, of course, they're on HRT, which can prolong this issue. And 50% of women are reported to have cysts at some time in their life. They're often multiple, they're often bilateral, and they're often asymptomatic. So if we look at impalpable cysts first, they're always diagnosed, obviously, on ultrasound or possibly on mammography, and they're anechoic. So when you look at them on an ultrasound, sound, they're like a black hole. If they're typical, regardless of the fact of bilaterality or if they're even larger, no treatment is required if they've got an absolutely classical appearance of a cyst. Atypical cysts pose a different problem. And the problem you probably find in general practice is that you see reports which say atypical cyst. And amongst atypical cysts, obviously there's the question of whether or not any of these are not cysts and are breast cancer. And this tends to really come down to the reporting of the radiologists. I think, unfortunately, if they say that, often they'll say a cyst is septated and it's atypical. Now, I don't believe that that needs a biopsy, but if the report starts to call it atypical and recommends biopsies, then it's a bit of a hard position to be in. There are occasionally cysts that are associated with the cancer, but they do look atypical. They've usually got some architectural disturbance around them, or they've got intracystic solid lesions. So if you're uncertain whether to have it biopsied or not, it's possibly worthwhile talking to the radiologist or having the patient reviewed before you proceed to a biopsy. What about palpable cysts? What about those cysts which come along and they've got a new lump? Well, who do you aspirate and who do you don't aspirate first? First of all, if I see a patient and it's the first time that they've come with a lump or a palpable lump, even if the breast imaging suggests a simple cyst, I will aspirate it. And I do that, first of all, to reassure the patient that this is a simple lump and it's removed just by simple aspiration. And I also want to make sure that on this particular occasion, when I'm aspirating the cyst, there are no residual findings. You also aspirate them if they are atypical, obviously, on the imaging, and you're uncertain of their nature. Having aspirated, you've got to decide, what do I send for cytology? Now, those that are atypical and you've biopsied for that reason, they need to go for cytology. If you aspirate and you get a bloody aspirate, then you send for cytology. If you aspirate and you've got a residual mass, then you need to go on and reevaluate this patient. Firstly, you send the fluid for cytology, but also I re-ultrasound this person to see whether or not I've completely emptied the cyst. And it might be that with a repeat ultrasound, it's a residual fluid which is loculated, which you haven't aspirated, and once it's aspirated, the lump disappears. Or alternatively, it then shows up that there is some distortion or solid abnormality which needs a further biopsy. The third thing is, when do we operate? Well, obviously, if anything's atypical, the cyst is going to come out. Alternatively, if it's continually recurring and problematic for the patient, it needs to come out. And thirdly, if there is an intracystic solid lesion which is clearly visible, that probably will need to come out to exclude an intracystic carcinoma. But all of the others we manage conservatively and don't excise. The question then is, how do you follow these up? Initially, I used to get everybody back after 6 weeks, but I stopped that after some years into my practice. And now, if I'm comfortable that I've got a normal benign cyst and it's completely aspirated and there were no atypical findings, I ask the patient to come back if they feel the cyst again and it's bothering them. You don't have to follow them up with regular ultrasounds. Only if there is some concern and you didn't feel it was enough for excision, but you thought you'd just like to look at it again in some months. But generally speaking, I just return the patient to self-examination and reviews as needed. If there are multiple cysts, I think there is an argument possibly for repeating ultrasounds more frequently, possibly annually, maybe initially 6 monthly, just depending on what you're looking at, only because it's sometimes not easy to be confident when you see a person with numerous cysts that you're not missing anything amongst all of that. So in conclusion, after looking at breast lumps, solid and cystic, the majority of them are benign. Use the triple assessment or triple testing to obtain a diagnosis. And I'll just make a comment about core biopsies here. If you send off a person who you clinically think has got a fibroadenoma, and the ultrasound says, yes, it looks like a fibroadenoma, and you take a core biopsy or you arrange for a core biopsy, and that comes back showing benign breast tissue, that is not a concordant triple assessment. You need to see in the core biopsy fibroadenoma, because when a core biopsy is performed, there is an error margin, and the core may not have been taken from the lesion that you were trying to core. So I'm always quite careful or wary when a core comes back when I'm targeting a specific lesion and I get back benign breast tissue. Sometimes that is acceptable because you're coring something which you think is probably benign. But when you're looking at a definite or fine solid lesion and you're looking for a specific biopsy, you want to see that on the core. Now, once you've established that the core biopsy and the whole triple assessment process is benign, reassure the patient. It doesn't always work, and sometimes they still want the lump out. And you can always offer them early follow-up, and that sometimes will overcome an issue when they're very anxious. As I said, with fibroadenomas, I tend to, on the first instant, have a look at them in about 6 months with a repeat ultrasound. After that, I return them to routine follow-up. With cysts, if they're very numerous or multiple, I'll probably follow them up a little bit more closely with ultrasounds, just because of the possibility that you may be missing something. And if you've got any concerning features or atypical findings, then you really need to refer them for further assessment. And there's no harm calling your breast surgeon and ringing up and saying, what do you think? I frequently get phone calls regarding patients, whether I think it needs to be seen or not, or there's anything that should be further done. And I discuss it with the GP, and I think that's a very useful and helpful thing for most general practitioners. Now, I don't know if you want to stop for half an hour. Kylie, are you there or? Hello?
Yes, I am.
Yeah, I don't know if people ask questions or you want me to stop or keep going.
Yeah, look, a few questions have come in, so if you want to take them now, I can put them to you now.
Well, if there's not a lot, I can do it at the end. If there's a lot, I'd probably better do it now.
Why don't I? There's sort of there's 4 or 5 here that.
Sure. Okay.
So just going back to mastalgia, someone's asked, do topical analgesics have any role in mastalgia?
No, not as far as I'm aware. There's been studies on all these sorts of things, and mostly they're unvalidated by any sort of statistical support. So topical analgesics, unless you've got, I put it to you like this, if somebody has got focal asymmetric non-cyclical discomfort, maybe there's a focal issue that maybe a topical analgesic might be useful for. But bilateral cyclical mastalgia, I don't believe it's got any place.
Okay. A couple of questions along this line, but if you've got multiple fibroadenomas, and let's say we're using some of those criteria that you gave us, say greater than 3 centimeters, atypical features, significantly enlarging, do we need to biopsy all of them?
No, look, that's a difficult situation. And it's like the multiple cysts. With multiple fibroadenomas, I see the patient. I look at the x-rays, obviously. Most of them are so typical, it's not even a question. And I'll usually biopsy anything that's a little bit larger, or the larger ones, maybe 2 of them or 3. and then monitor them a little bit more closely initially to see if there's any variation or change. Look, you can go to contrast mammography, and that's what I mentioned initially with contrast mammography, that if you've got multiple lesions, it may be useful in separating fibroadenomas from neoplastic lesions, because the neoplastic lesions have got the abnormal circulation with the contrast leakage, which will make them look different. So certainly contrast mammography can be useful in that place. But if I'm comfortable that I'm looking at somebody who's young with multiple fibroadenomas, which is the usual scenario, I'll probably biopsy one or two larger ones. And if they come back confirming fibroadenoma and the others look completely benign, I'm usually happy to watch that, and in about 6 months or so get a follow-up ultrasound.
Okay, great. I might just ask two more questions here and then we might keep moving, because I think they're things that you have touched on, but they are definitely worth reiterating. So someone has just asked if you could reiterate what you mean by triple testing.
Oh, well, triple testing means a comprehensive clinical examination, breast, axilla, supraclavicular areas, followed by routine breast imaging, which is ultrasound mammography usually, and I did touch on MRI and contrast enhanced mammography, but I don't want people to think that they're two tests that they need to do for everybody to complete triple testing. They're used selectively, and a non-surgical biopsy, which usually is a core biopsy, but under certain circumstances, a fine needle is acceptable, such as aspirating a cyst, or if you've got other health issues with the patient. Sometimes we've got people on significant anticoagulation and all this sort of thing, and we want to get a biopsy, and we'll try a fine needle initially. But that's what a triple assessment is. Now, if all of those three come together and give you a definite diagnosis and a benign, then you're almost 100% accurate in what you think the patient has got. But if any of those deviate from benign, then that needs to be further assessed. Does that clarify that?
Yes, I think so, definitely. And just following on from that, so I think that explains where fine needle and where core biopsy should be used. Is a core biopsy a lot more painful? Someone has asked.
It is a bit more uncomfortable. Look, it depends on the radiologist yet again. You know, there are radiologists who are really very efficient, very good at doing these things, and there are others which may be less experienced in their career. A fine needle is just a fine needle, so it's pushed with ultrasound straight into the cyst. It should be fairly pain-free. A core biopsy is a gun, and what it does, it fires a cylinder over a blade and takes a core. And that obviously can be more uncomfortable, and often they'll do it 2 or 3 times. So yes, it is a more uncomfortable procedure, but it's going to be much more useful diagnostically.
So if we can palpate a lump, so we've done our physical assessment, we can palpate a lump, would you send them, when we're sending them for imaging, would you automatically send that for a biopsy, or would you wait to get the initial imaging back before you make the decision to biopsy?
Well, I think you probably find in your practice the radiologists call you and say, do you want me to biopsy?
Yeah.
You know, if it's a simple cyst, I mean, it'd be, you know, speak to the radiologist. You know, it may not need a formal biopsy, just a simple aspiration. You know, sometimes a core biopsy ends up with a very large hematoma, and it makes it difficult then to assess the patient clinically. It depends on your radiologist, but sure, if you've got a lump and you want to resolve it quickly, if it's a cyst and they want to aspirate it, I think that's reasonable and fine. If it's a solid lesion and they want to core biopsy it, it will make things move more quickly. But having said that, you know, if the patient is referred, like we have core biopsies on the day that they're seen, you know, at St George. So when I see them, if they come with an unbiopsied lump, it'll be biopsied almost always on the same day. But sure, if they offer you a biopsy, I don't think there's any great harm with that.
Okay, great. All right. Well, I think we might keep moving from there if that's okay, Peter.
Yeah, I don't even know how long I'll be going on. Nipple discharge and changes. Now, this is another common thing that I see, and I've listed the most common causes: papilloma, that's usually single duct; ductectasia, which is usually multiple ducts; DCIS or carcinoma rarely will present with discharge from the nipple, which can be blood-stained; hyperprolactinemia is usually bilateral and numerous ducts; Paget disease, which is sometimes associated with nipple discharge; eczema, which is usually the areola, and sometimes medications can lead to nipple discharge. The most important thing in nipple discharge is to take a history. Is it spontaneous or on compression only, meaning only when the patient squeezes their own breast? Is it unilateral or is it bilateral? Is it multiple ducts or single duct? What color it is there a pregnancy? And what drugs are they on? And they're the only questions you really need to ask. Now, if it's multiple ducts and on compression only and yellowy green, that's always benign, physiological, and of no concern. It's when a nipple discharge is spontaneous, unilateral, and when you compress the breast when you're examining the patient, it's coming out of a single duct, and it can either be clear or bloodstained. That's when there is almost certainly pathology present and somewhere in the ducts leading up to the nipple. And that's considered abnormal, and you need to exclude local pathology. So with nipple discharge, the ones that we tend to become involved with surgically are these: the spontaneous unilateral single duct discharge, regardless of clear or blood-stained. What investigations do we do? Well, mammography and ultrasound, obviously. And if there is a visible finding, biopsies are taken, and not infrequently that'll be a papilloma. Cytological assessment of the nipple discharge is really of very limited value. I don't use it actually, but if somebody's done it and it's positive, then it's very significant. But, almost always you get back a result which is really not all that helpful. Ductography or a ductogram, it's not a readily available test. I actually don't think it's of great use because it's not going to change the way you handle the patient. It's uncomfortable and I don't arrange for it. It used to be used 20 years ago, but really very little today. And obviously, if you've got bilateral discharge, which is profuse and milky, a prolactin level is needed. And they're the main tests that you might use in assessing nipple discharge. Now, what do you do about nipple discharge? Now, if it is spontaneous and from a single duct, and you've got normal clinical findings and imaging, these patients still need a duct exploration because it's very likely that there's a papilloma somewhere in one of these ducts. And although papillomas are generally benign, a few of them are associated with breast cancer, and you cannot differentiate them. So if you do have spontaneous single duct discharge, that needs to be seen, even if it's got normal clinical findings and imaging, apart from the discharge, and they require a microdocectomy or duct exploration. With abnormal imaging, they're obviously being biopsied, and if it comes back as a papilloma and not a cancer, or some other variety of pathology, you need to excise it with the discharging duct. And what we do there, and the slide I don't have a pointer unfortunately, might not be all that clear, but there's a hook wire going through the red line above the scar, which is periareola. There's a probe going through a duct through the nipple up to more or less the area where the hook wire is, and then we excise the duct up to the nipple and the lesion and send it off for pathology and close the wound. So nipple discharge, if it's bilateral and if it's yellowy green, and it's only when people compress, tell them to stop compressing the breast. It's physiological and of no concern. I mean, it's very normal to have fluid in the ducts of the breast, which is usually reabsorbed, and nothing further needs to be done. Hyperprolactinemia, then you look for or galactorrhea. You look for causes of hyperprolactinemia, such as pituitary lesions, or medications such as HRT, antiemetics, OC, and the list that I've got there, which I feel fairly sure that you're aware of. So it's the spontaneous unilateral ones that really do require surgical intervention. I've put this slide up just because you may or may not have seen Paget disease, and it's part of the nipple abnormality spectrum and the one that everybody's frightened of. If you look at this slide, you'll see that the areola is effectively is really quite normal, but the nipple is quite altered. And with Paget disease, the nipple has to be altered. Its cause is unknown, but it's often part of a cancer problem, and they either develop de novo or spread from an underlying carcinoma. And here's another Paget disease, which is presented with just ulceration on top of the nipple. And once again, you can see how the nipple's involved and the areola is spared. When you have eczema involving the areola, that's generally not Paget's, and that's much more likely to be a benign eczema, such as dermatitis spongiosum, which will settle quite quickly with topical steroid application. But this situation where the nipple is actually involved is a different story. And if we do have Paget's disease and we've investigated it, and the only finding we've got is Paget's on the nipple, which will need a biopsy to confirm, and there are no other intramammary lesions that have been noted that require assessment, then we can usually manage this like a DCIS situation with wide excision. And in this situation, we tend to excise the nipple areola complex, and the patient is left with a transverse scar over an otherwise normal breast, and that can actually be reconstructed in the future should they so wish. What about inflammatory breast conditions? Well, there's the pregnancy-associated mastitis, non-lactational mastitis, and periductal mastitis, which comes under the non-lactational group, and other rare forms which you may or may not have had patients with, such as granulomatous mastitis, which is a bit of a nightmare to treat, and inflammatory breast cancer, which is always the concern. With lactational mastitis, which I'm sure a lot of you have had to manage, the treatment is conservative. You have to educate the person how to massage the breast and empty the breast. Lactational advice, make sure that the child is attaching properly and the nipple is protected. And antibiotics. And what I would comment here is don't leave antibiotics till late, because the later on that you leave them, the more difficult it often becomes to treat. So if you really think they've got a mastitis starting up with erythema and so forth, start the antibiotics earlier rather than later. Now, if that fails, or if these measures fail, you may need to aspirate the collections. And if they're fluctuant, I do it in the rooms for the patient, get them back every 3-4 days for a while till it ceases. But occasionally that doesn't work, and you need to move on to a surgical drainage. But that's far less common than it used to be. And if you can, encourage their mother to continue with breastfeeding if they can tolerate it. But sometimes it's intolerable, and I certainly, if it is so, do not push them too hard because it makes them very miserable. But if you can, encourage them to continue with breastfeeding. It'll also help in the management of the mastitis. Now, non-lactational mastitis is a different issue. It's associated with underlying cysts or ectasia or some form of pathology. It can happen post-radiotherapy, but the treatment really is as it is for lactational mastitis: antibiotics, aspirations, either by hand or under ultrasound guided if needed, and hopefully it settles. But if you end up with an abscess which doesn't settle, you may need to surgically drain it, but that really is very uncommon. And if there is underlying pathology there, you may need to deal with it. Now, the issue here is to exclude an underlying malignancy, and you'd be particularly concerned if you'd started treatment on these people or one of these patients and they hadn't responded to antibiotics. Now, inflammatory breast cancer makes up, and I know this is not a benign condition, but I just want to go over it a little bit briefly, makes up a small percentage, maybe 1, 2, 3% of breast cancers. The erythema that you see with inflammatory breast cancer is much the same as you might see with an infective mastitis, but it can be over a very limited area and not always covering the entire breast. That's usually very advanced inflammatory breast cancer. There may be a mass underlying the erythema, and if it is a very extensive, the breast feels very heavy as compared to the other breast because it's full of tumor. And often it's not tender, which differentiates it from a massive inflammatory process, which would be tender and hot. Peau d'orange is a very constant feature I find with inflammatory breast cancer, and I've actually seen, I think, 3 of them in the last 3 weeks. Lymphadenopathy is variable, although it's reported as being there. It's not always palpable. The nodes are not always palpable. And often the other signs of inflammation are absent, which you may have expected, like being febrile and being very painful. So inflammatory breast cancer, if you see somebody who's got erythema, non-tender, the breast feels heavy, there's peau d'orange, and there are no other signs consistent with infection, and particularly if you've given them a short course of antibiotics and they haven't responded, then just be wary that you may be looking at inflammatory breast cancer. Periductal mastitis is another not uncommon thing that I see. It presents with periareolar inflammation, often discharged through some sinuses that develop. It's commonly a recurrent and chronic problem, and it's a problematic condition. 90% of patients are smokers. The treatment is difficult because we certainly try and avoid operating as far as possible. We use antibiotics, and we try and encourage the patient to stop smoking, but that really is an impossible mission. I always ask them to hand over the box of cigarettes they've got with them, and I've yet to get a box of cigarettes from anybody. So I think that is a real problem. And if they are refractory, if they're ongoing, you've had repeated infections and sinus formation, you may then have to resort to surgery, and that's a central duct excision or removal of the ducts underlying the nipple. That's also not a great operation because it's often complicated by problematic wounds and inflammation, so it is a problem thing. Gynecomastia, another common thing that I referred. It's either unilateral or bilateral, and this is a sort of image of the more common presentation I see. Somebody who's been to the gym for the last 2 years and denies any use of steroids. It's mostly benign, and 25% of them are idiopathic. In the history, you particularly look for what medications that they've been on, and alcohol and steroids are the main ones. And you also need to exclude underlying medical issues such as liver disease, where they don't break down their estrogens. Hypothyroidism is associated with this rarely, as is renal disease. Testicular tumors with secretion of abnormal levels of hormones such as estrogens. I've seen one of these in my life, so it's pretty rare, but you do get patients who will develop gynecomastia on the back of endocrine tumors. Hypogonadism and elevated prolactin will do this as well, and I've been through that previously. What do? You've got to investigate them. You image them because you can find, obviously, breast cancer in men. And particularly, you need to be careful with the unilateral ones, although we're currently about to write up a group of 4 men with bilateral unexpected breast cancers. An endocrine screen, I perform an endocrine screen. I look at the prolactin, the beta-HCG, and the estrogen, the liver function test to make sure that these are normal. And if you think that it's not absolutely typical, then don't hesitate to have a biopsy performed to confirm the diagnosis. If you've established a cause for the gynecomastia, then obviously try and treat this, and that might be to encourage some of these young guys to stop using steroids, or it might be associated with medications that the patient's receiving that you might be able to cease. And if you can be conservative, it's particularly in young people where they're idiopathic, this can be a transient event. If you have to go to surgery, the most commonly performed procedure is a subcutaneous mastectomy, and that usually gives a very good cosmetic result. It can be done usually through a periareolar incision. The breast looks relatively normal after that without anything in the way of scarring. They may lose a bit of sensitivity of the nipple, and you mainly do this for pain and cosmetic reasons. Some of the plastic surgeons are also using liposuction and avulsion for this, which may be as effective as a subcutaneous mastectomy. Now, another issue that's referred to me not infrequently are imaging issues such as calcification. Now, calcification is present frequently. It's most commonly benign, and I need often to reassure a patient that in itself is not a sign that you're going to get cancer or is it precancerous, and it is a secondary event. Because from what I can see, a lot of people say, oh, you've got calcification, you're going to get a cancer. And you need to reassure the patient. Now, when the calcification is reviewed by a radiologist, it'll generally fall into 3 groups. Those classically benign, and they'll just report them as benign. Those that are highly suspicious or definitely malignant, and they'll be reported in that way. And it's very clear what you need to do with those patients. And the ones that are classically benign, you reassure them. The ones that are potentially malignant, you're going to biopsy. But there's a whole lot in the 3rd group which are intermediate. And these are the ones that you've got to be careful with, and you've got to decide how you're going to manage. Personally, if I see people with what is called indeterminate calcification, I have it biopsied, because I've seen so many now, particularly through breast screen, where they really are very vague, and they end up with DCIS. And these tend to be like very tiny foci of some clustered, possibly pleomorphic calcifications. And if you've got any doubt, I think you need to refer it so that it can be assessed and a decision made as to what to do. Now, if they're biopsied, this goes back to the previous issue of core biopsying, because you either core biopsy these or vacuum biopsy these. If you don't get calcification on the biopsy, you haven't progressed, and they may require excision. So be cautious with these indeterminate calcifications. I'm not going to talk anymore about risk assessment. I think we're running out of time, but use the Breast Cancer Institute site, and there is a tool you can use called FRABOC, Family Risk Assessment for Breast and Ovarian Cancer. You can log on to that, put in the patient's details, family history, and so forth, and it'll give you risk assessment. I do see patients who come like this, who are concerned because of their family history. So not all of them have got a significant family history. We go through it all, make a decision how much of a risk there is, and then what sort of follow-up they need. And it might be that if they're young, they need regular MRIs as opposed to mammography. but you need to assess that with each patient as to their risk. I was also asked to touch on breast cancer follow-up, and that's a very varied type of thing. First of all, I'd just like to make a comment that I think general practitioners really need contemporaneous information and involvement as far and as soon as possible, because most patients really, I think, need to be in touch with their GP if they're going through an issue like this. And it's very hard for general practitioners to manage what's going on if they're unaware of what's happened to the patient. So as far as possible, I think you need to be fed the information as quickly as possible, firstly about the diagnosis, secondly what the plan of management is, and thirdly what's happening once treatment is commenced. Specialist follow-up depends on the disease severity and how many specialists are involved, and also the time from when the treatment was instituted. And you probably often see patients who seem to be seeing one of us frequently and all overlapping, and you wonder whether or not that's any use. We do try to not see patients at the same time unless necessary, and we try and share the follow-up between us depending on who feels they need to follow up the patient. So if you've got a patient who presented very, very aggressive disease, who required chemotherapy and chemotherapeutic follow-up, then they're going to see the patient, at least initially, frequently. The radiotherapist far less frequently once they've delivered the treatment that they need to. And the surgeon, initially, I like to see the patient twice a year for the first couple of years, and then depending on what's going on, we'll probably drop them down to once a year with their annual breast imaging, but that needs to go on for at least 10 years. And I just want to point out that's not even so much about the tumor that we've dealt with, although that's important, but we know that patients who have had a unilateral breast cancer run a 1% risk per annum of developing a cancer on the other side, which cumulatively adds up to 10% over 10 years. So we're imaging as well to monitor the contralateral side. And also we see them because if they've got any symptoms that concern us, that we can get onto it and examine them as soon as possible. I think that's probably all I need to say, Kylie, if that's okay with you. And then I can answer any further questions as you receive them.
Yeah, wonderful. Thank you. That was really informative, and I think really touched on a lot of the things that we commonly see in GP, and it feels like you've given us a nice framework of how to investigate things, and also I found more confidence in knowing when to refer on. So that was great. Thank you.
Okay.
There are a few more questions, so I might group them together. Then just going back to mastitis, there's a couple of questions. So if we've got negative imaging in someone who's got recurrent mastitis, how many episodes do you think it's reasonable to let pass before we refer them on?
Pregnant or not pregnant?
It doesn't specify in the question, but I guess.
All right, well, let's say this, that if the patient's pregnant and they've got mastitis which resolves with treatment and disappears, then you don't need to keep re-imaging unless you think another area is developed and you may be developing a collection which might need aspiration. All right. Now, in non-lactation, does that answer that one, do you think?
Yeah, I think so.
In non-lactational mastitis, if they've responded to treatment and the signs of mastitis have completely disappeared, and you've imaged them after the mastitis, and that is completely normal, I don't think you need to do anything else. Now, if they represent with mastitis 9 months later, and you go through the same process, you may obviously repeat their ultrasound at that time to see whether or not you've got an infected cyst or very significantly dilated ducts. But if they've responded once again to the usual courses of antibiotics that you might prescribe, then probably you don't need to do much more.
Okay.
Okay.
Yeah, lovely. A question was, how do you determine if a discharge is from a single duct clinically?
Right. So when you examine these patients, and I'll just put the nipple up there, what you do is you compress, well, let's go back to that one, this one. What you do when you examine a patient, obviously you palpate right around the breast. Excuse me, but if they've complained of discharge, then what you need to do is compress the areola and around the areola and look at the nipple. And it'll become very clear to you when the discharge appears that it's coming through a single duct. You'll just see one drop of fluid, which is either clear or bloodstained, come through that duct. If you compress and you see numerous little drops of yellowish fluid or whatever fluid come through, then you know it's multiple ducts. But it's very clear when you compress the breast and you get the discharge that it's coming through one duct because you actually see one drop appear. Excuse me.
Okay.
Is that all right?
Yeah, yeah.
Yeah, I don't know if
I think you've probably answered this, but should all non-lactational mastitis be imaged?
my personal thing is they should be. Well, firstly, during the mastitis is one point, and what do you do after the mastitis? If they've had imaging 2 months before, obviously, you think you're dealing with a simple, straightforward, ductictasia, which has become infected, or they've got a cyst on the previous imaging, or they've got dilated ducts, you're going to have a visible cause. And I don't think you need to repeat the imaging unless they don't respond, and you might need to aspirate something, or you're concerned that there are some other clinical findings. If they haven't been imaged recently, it's pretty unkind to put somebody with painful mastitis in a mammogram machine. So what you need to do is to get them to settle down. You might get their ultrasound done, but then perform routine imaging afterwards, just to try and obtain a diagnosis as to what's happened. So it would be really the scenario that you're in. So somebody who's walked in and said, "Oh, I had my mammogram and ultrasound 8 weeks ago, and now look what I've got." You probably would be comfortable just treating, right, and not doing much more, particularly if they settled very quickly. Somebody who hasn't had mammography and ultrasound for a year, you might have an ultrasound performed at the time or shortly after the mastitis is treated, and then a mammogram when they've settled.
Yeah. Okay. Thank you. There's just a couple more. A question: are cabbage leaves on mastitis any help?
Well, the lactation nurses have done that to my patients up on the wards. I don't think they're of any real help. The cabbage leaf thing is really possibly it gives them a little bit of comfort on top of a painful breast, but there's no evidence that using cabbage leaves, look, it's an old thing that's been used, but the answer is I don't prescribe that sort of treatment.
So, an ice pack or anything just for comfort.
Well, whatever makes them comfortable is fine.
Yeah.
I'd use, whatever makes them comfortable is good, obviously. If the ice pack works, then put the ice pack on. You can use some analgesia as well if they're in a lot of pain. But the cabbage leaf is not going to improve the mastitis. It's only a local comfort thing. So just a general ice pack would be just as efficient.
Okay. I've only got one more question here. So if anyone else has any questions, this would be your last chance to get them in. And this is, I guess, a clinical example. How would you manage ongoing bilateral lactation despite no breastfeeding, and they're now 8 months post-delivery, and unfortunately it was a stillborn birth, which is very unfortunate, but so 8 months post-delivery and still lactating?
Yeah, well, it's a difficult issue. Is the person compressing the breast? I'm not sure, because sometimes these things are promoted by patients actually compressing their breasts. They see the discharge and they keep pressing it to see if it's going on. So the first thing I'd do is make sure that the person is not compressing their breasts. The second thing is, it's not all that uncommon that we will see people or patients who have got a small amount of bilateral ongoing discharge from the nipples following a pregnancy. I try to reassure them and not do anything and don't use medication. The third thing is that if it's profuse, I guess you would be obliged to get at least a prolactin level to make sure that they don't have also another issue going on, such as a pituitary adenoma. And you need to check their medications to see if they are in anything which might be leading to the discharge. But if it's all clear and it's all benign and there's no other issue, I would just wait.
Okay.
I mean, I presume you can have a breast ultrasound, but it's not going to be very useful, I think, in that situation.
Okay. There have just been a couple more questions, so I might save that to the end for anyone else trying to send some through, but some of these are, I think, quite relevant. Any comments on breast implants and how this can complicate assessment and contribute to breast symptoms?
Yeah, sure. Well, breast implants, as we know, are very common today, and we see them frequently. They're not always put in the same position. Some are put beneath the breast tissue and some beneath the muscle. They can complicate, obviously, your breast examination, particularly if they've leaked and you develop lumps, and you can develop axillary lymphadenopathy with silicone in them. It's got a very typical appearance. You can mammogram these people and you can ultrasound them, but I think that's one of the one of the indications I put on for probably MRI if you're in real trouble. So yes, they can complicate breast examination, but we can use conventional imaging. And if we've got any doubts or issues or concerns, that's where we would really suggest the usage of MRIs. It's not a contraindication to implants, in the fact that you might have some difficulty in examining them, but we can overcome that. I guess the other person that you've got to be careful of are the people who develop after breast implants, particularly long-term, the possibility of developing these atypical carcinomas in the capsule around the implants. I've not seen one, but if you see someone with an implant that has sudden enlargement or sudden swelling around an implant, it may well be this anaplastic lymphomatous disease that we can see with textured implants, and you should be wary of those. Send them off for testing. They need an aspiration and they need to be sorted out. Okay.
Yep. And someone said, sorry if this has been asked and answered, but does the triple assessment always need to include mammography? Is ultrasound alone acceptable, particularly in younger women, for example, 20 to 30?
To be fair, yeah, well, it doesn't always. And if you certainly, that question really relates to the 23-year-old with a fibroadenoma, where a mammogram is going to be pretty useless. So I think it's perfectly acceptable to just have a clinical examination. If your ultrasound is consistent with a fibroadenoma, or let's say a cyst, and then have the fine needle aspiration or the core biopsy, that's adequate. You do not need a mammogram at that point.
Okay. Last question then is, do you have a preferred brand for B vitamins for breast pain?
No.
Okay.
I don't.
Well, that's short and simple.
I don't.
Okay.
I send them to the chemist. I send them to the chemist, and wherever they're going, they'll get the vitamin B.
Yeah, lovely. Well, I'd just like to say thank you again, Peter, because I thought that was a really informative talk. So thank you for taking the time to present tonight. And thank you to everyone who has attended. Don't forget you'll receive an evaluation link in your email inbox shortly and you need to complete it to get your points. Certificates and points will be provided within 2 weeks.
Kylie, I just want to make one more comment, if that's all right.
Of course.
And that is,
yes.
that, if in general practice, it's very easy to ring up, I think, and to ring one of us. And if you've got an issue or a concern and you think you might resolve it with a phone call, you shouldn't hesitate to call us, because we'll always take the call or call you back and try and help you out. So just keep that in mind.
Thank you. Yeah. Okay. Wonderful. Well, thank you again, and good night.